Welcome back. Now we are going to take a look at what we've learned throughout the course and applying that to specific case studies. Before we get started, I really want to emphasize that these case studies can be very difficult to listen to, especially if you have your own personal loss story. So please honor your own needs and your own emotions. If you only need to take one case study at a time, that is perfectly fine. Maybe you want to give yourself a couple days in between, whatever you need to do. But I just want to make sure that you honor yourself because these can be very difficult to listen to. The case studies I'm going to present come from that study that I've been referencing throughout this course. And in addition to interviewing the participants, I also gave them the perinatal grief intensity scale, which I mentioned earlier. Overall, 75% of the parents in my study experienced intense grief, including 50% of the men. So with each case study I present, I will let you know what their grief score was. We'll complete the first case study together so you kind of have an idea of how the flow goes and what's expected of you. And please feel free to refer back to the materials in the course, especially the patient-centered care, communication, and shared decision-making slides, as well as the materials that have been given to you in the course materials. The handout that talks about different care interventions to help parents actualize the overall goal of having no regrets are especially helpful as we go through these case studies. So first, we're going to talk about Chloe. Chloe is a 24-year-old woman who recently learned she was pregnant. She and her fiance were surprised but very excited to welcome a new child. At Chloe's first checkup appointment, the sonography technician tells her something is wrong and the doctor will be right in. When the doctor arrives, he states, "The fetus has anencephaly, you will need to terminate. The receptionist can help you make an appointment." He then walked out of the room. The next week, Chloe and her fiance went to the clinic for a scheduled termination. After hearing their son's heartbeat and learning his gender, they decided to carry the pregnancy to its natural end. When Chloe returned to her doctor and told him her desired course of treatment, he responded with, "If you don't terminate, I'm not going to continue caring for you." When asked about organ donation, the doctor told Chloe, "No one will want the organs." When Chloe was interviewed 3 months after her son died, she was unable to donate her son's organs. She cried and yelled throughout her interview, but thanked the interview for listening to her story. Chloe's grief score indicates she was experiencing intense grief. So let's look at a few questions about Chloe's experience. Question 1. How could you help Chloe understand what it means to have a pregnancy complicated by anencephaly? Let's reframe Chloe's diagnostic interactions with the provider using a high-stakes communication model. Now that high-stakes communication, Chloe was by herself at the appointment, so they would ask, "Would you like to have your fiance or a support person with you?" Considering the environment is an important part of that high-stakes communication. Offering a warning shot, such as, "I have some difficult news to share with you," or "This will be difficult to hear," can help prepare Chloe and help her start to build the defenses a little bit rather than blindsiding her with shocking information. Remembering the environment. Is Chloe dressed? Is she warm enough? Does she have the jelly on her tummy still? Those are all things that can be helpful in setting the stage for the conversation. Now in the actual conversation, in helping Chloe understand what anencephaly means in her pregnancy, maybe that conversation takes place a few days later. Maybe at the initial appointment, she's given the name of the diagnosis and maybe some materials or websites to look at, and then told to come back in a few days after she's had time to think and process. Allowing her time to process is really helpful in setting the stage for her then to make the decisions that are consistent with her needs, beliefs, and values. Now let's look at question 2. What are some interventions that you could implement to decrease Chloe's risk for complicated grief? Now, we already talked about a few interventions such as changing the environment, offering the warning shot, providing extra time. But one thing that's also important is normalizing Chloe's reaction. Remember, grief is perfectly natural, especially in this situation, so letting her know that what she's experiencing is normal. It doesn't make her pathologic or weak or anything like that. Telling her that it's okay to be sad, it's okay to be angry, can help her not feel guilty about the emotions she's experiencing. You could also have Chloe take a grief assessment tool such as the perinatal grief scale or the perinatal grief intensity scale, something to assess the level of grief intensity or Chloe's risk for developing complicated grief later on. This allows you to allocate those bereavement resources that may be beneficial to her recovery process. It's also important to let Chloe know that she's not alone. Maybe she has a support group that she would like to belong to, either in her local community or in an online community. There are more available support groups online than in person, but those resources are available, and providing her with those options is important. Now, question 3, what resources might be beneficial for Chloe? Obviously, a perinatal palliative care program would be ideal. However, not every hospital has this type of program readily available. If these resources are not available in the immediate community, networking is important, and looking at where you can find these resources is very helpful, and collaborating with other healthcare systems to meet the needs of the parents is important. Social workers and intercollaborative members of the team, chaplains, other nurses, doctors, psychologists, are important members to develop this healthcare team in meeting Chloe's needs. And the bereavement resources are important to allocate to Chloe and her fiance during this time. There are a number of organizations, as I've mentioned, that may provide the beneficial support services if they are not available in your local area. Now I Lay Me Down to Sleep is one example of a photographer who takes pictures of parents for the birth, that in order to provide them with that memorabilia, those mementos that they can continue to bond after the completion of the pregnancy. There are more resources listed on the Project Poppyseed website, as well as on the handout that you've been provided. And question 4, what could follow-up care look like for Chloe? After her son was stillborn, unfortunately, Chloe did not receive follow-up care. So doing something like mailing sympathy cards to Chloe and her fiance could be very meaningful. Offering follow-up phone calls at strategic intervals is also very important. This allows clinicians to assess Chloe and her partner's grief intensity, as well as to provide grief resources and bereavement resources. And while Chloe may not take up the offer of the resources offered, it is important to at least provide those. In having this continued connection with Chloe, the healthcare professionals are able to assess and reassess her needs, and Chloe and her fiance know that their pain and their experience has not been forgotten. In our second case study, we're going to talk about Mac. Since we worked together on the first one to get a hang of what this whole case study question answering is going to look like, I'm going to read the case study, and then you can go through afterwards and answer the questions. Mac and his wife Samantha, pregnant with twins, learned that twin A, Mariah, had anencephaly, while twin B, Ethan, was perfectly healthy. Mac and Samantha decided not to intervene with the pregnancy, despite the provider recommending a selective reduction. Mariah survived the remainder of the pregnancy and was born alive via cesarean section. Ethan was perfectly healthy. Though Mac was given time off work, he chose to return to work a week after Mariah was born, stating he could not sit around and wait for Mariah to die. Samantha had insisted that someone hold Mariah at all times, fearing that she would die alone. Mac and Samantha were both exhausted from holding Mariah day and night, Mac was worried that his 2 surviving sons were being neglected and did everything he could to keep the house running. On day 33, Mariah died while sleeping on Samantha's chest. Samantha was not awake when Mariah died and was devastated to learn her daughter died while she slept. Mac was interviewed 12 years after Mariah died. He cried frequently throughout his interview and stated over and over how guilty he felt for everything that had happened. When asked by the interviewer if he had anyone he felt comfortable with talking about Mariah and the guilt he felt, he stated, "This is actually the first time I have ever shared my story. You're the first person to ask me about her." Mac's grief score indicated that he had intense grief, and his was the highest score of all the participants. I would like a moment to say it's very important for parents to be able to share these stories. It was 12 years of silence that Mac experienced before being able to share his experience with Mariah. So now you can go ahead and answer the questions. Once you've finished that, we'll come back for our 3rd case study.